which is a long-term multi-county initiative of the KP Reynolds Charitable Trust. She's also an investigator on an NIH-funded study of approaches to hearing screening for elderly in primary care settings, and is a Robert Wood Johnson Foundation interdisciplinary research leader. And then finally, we'll be hearing from Dr. Tran, who's Vice Chief of Education in the Duke Division of Community Health in the Department of Community and Family Medicine. Dr. Tran is the director of the Duke Master of Health Sciences and Clinical Leadership Program, and is the course director for the Community Health Elective for medical students, Community Engagement Elective for the Master of Biomedical Sciences Program, and serves as third-year study program director for the School of Medicine's Primary Care Leadership track. Dr. Tran has over 20 years of experience in implementing and evaluating community-engaged research and public health intervention programs aimed at improving the health status of communities. Please join me in welcoming today's speakers.
Thank you. Thank you all so much for joining us this afternoon. It's certainly a pleasure to be here, and again, thank you for your time in listening to us and a little bit about our programming and our research and evaluation that we've been conducting since 1998, as well as hopefully we'll have a bit of a robust discussion towards the end. As you know from the opening slide there, you not only have our names and affiliations, but I did include the website to the division, since we'll really focus today on our research and evaluation projects. And again, we'll, for the most part, with about 45 minutes, be able to give you an overall gestalt of those projects and a bit about each one, but certainly not get into the depth that would be possible if we were spending the entire time focused on just one of the endeavors. So should you have any questions or want to learn more, the website for the division is there on that first slide. Since 1998, we have developed work in a number of key focus areas. And when we first began as a division, as part of the Department of Community and Family Medicine, we were actually shared between the department and the School of Nursing, and were created to help build a bridge between Duke and the various communities it serves with a focus on vulnerable populations. And so over the years, what we've learned in our work, starting really from an operational standpoint in terms of developing clinical services and implementing clinical services, then evolving into evaluation and research, as well as developing educational programs, we've developed in the areas that you see there in terms of bringing clinical care closer to patients. So community, school, and workplace, and as you heard in the introduction, we do have a number of clinical services that are here in the Durham community as well as in our community surrounding Durham. We've looked to see how much we can do to maximize the skills of licensed professionals as well as unlicensed professionals in moving, you will, the capacity of the clinical team as well as community-based resources to not only manage the health of populations but improve the health of populations in the context of communities. So starting where communities are, working with them, and developing programs from that standpoint. We certainly have focused, as I mentioned, on vulnerable populations, and as we've evolved, we've become to understand more and more about health disparities and healthcare inequities, and certainly realize that we have a great deal of work to do going forward. And our work is focused for the most part on non-wealth communities. With that, we've spent a lot of time building not just efficacy at the individual level with our patients that we've worked with, but also capacity at the community level. And a focus clearly on the integration, as I mentioned a moment ago, on community and clinical services and advances, both in clinical settings as well as in community settings. And our approach has always been through intense community engagement, backed with data and always an eye to sustainability. A few of the programs, as I mentioned earlier, we do indeed have 3 neighborhood clinics in Durham. And for those of you that are living in Durham, you may have driven by or even frequented one of the clinics. So Lyon Park Community Center, Walltown Neighborhood Clinic, as well as a clinic in the Holton Career and Resource Center. We have 6 school-based health centers that are run in partnership with the Durham County Department of Public Health at 5 elementary schools, and we have one that is run completely through Duke Health at Southern High School. That center has just celebrated its 20th anniversary. Just for Us, which serves seniors senior and disabled who are living in public and or subsidized housing. We're in 13 buildings here in Durham County serving that population, and that program has been in existence since 2002. So a lot of programs that are long-standing, sustained, if you will. NPCC and Latch, that's Northern Piedmont Community Care and Latch, both are care management programs. NPCC serves the Medicaid population in Durham County as well as our 5 counties to the north. And Latch serves uninsured individuals living in Durham County. Both of those programs have been in existence since 1998 and 2002, respectively, and have now recently, just this past year, and I'm very excited to say this, moved over to the health system to help start the Population Health Management Office. So almost 2 decades worth of work in building interventions that help to manage the health of populations and improve the health of populations, now adopted and accepted by our health system to create a greater platform and capacity in that work. And Anh would not forgive me if I didn't mention the fact that the division also has a number of educational programs that we develop and operate, including a Master's of Health Sciences in Clinical Leadership, a National Duke J&J Nurse Leadership Fellowship, and a Learning Together program, which is a service learning program for medical students, PA students, PT students, all of our health professional students, and also encourages the participation of our undergraduate and graduate populations from the university side. In terms of our process for community engagement, I've summed it up just very briefly. It's a little bit more intense than what I have here on the slide, but certainly all of the programs are developed from community needs and the stakeholders, so both our community members and our partner health and human service entities, as well as other sectors, have helped us to determine what services need to be developed. We always continue in that collaborative vein in terms of the oversight of the programs. So whether it's steering committees of community stakeholders and partner organizations and faculty and staff or advisory boards, et cetera, there's always a hand of the group that helped to create the program that continues to help run the program and helps us with ensuring that the program stays relevant and understanding what tweaks we may need to make to the program. As I mentioned earlier, our programs do focus on populations facing health disparities and health care inequities, and they're designed to be financially stable. So in just a couple of programs I mentioned quickly, as you can see, they've been around for 10 and in some cases 20 years. So one of the things we never wanted to do was to develop an intervention based on a community need, and once the intervention was over, once the grant was over, off we went. So, and part of that obviously is the rigorous evaluation we apply to the programs to ensure that they're meeting the needs, but also that we can indeed maintain the service. And it's not always maintaining the service as the intervention may have been developed under a particular grant, but it's asking those very real questions of what do we know now that we didn't about the way we were delivering services, and what do we change about our service delivery platform to enable the program to continue. The key components of our interventions, we shared this with the IOM a couple of years ago, and it helped us to sort of really, I think, bring it down to a couple of key features. Obviously determining what services can be most effectively provided, where, when, how, right? The right service at the right time to the right person, the right types of providers, always data-driven, and that always means a number of data sources that we can get our hands on, whether it's local disease burden, utilization, what opportunities and resources may already exist. And then the cost-benefit process is always iterative. That's a ever-changing landscape, and I see a few heads nodding on that one, so it's something that we continue to monitor as we go forward in every single program, and always a team approach. The cost drivers we have typically looked at as being part of a large academic health system has certainly been overuse around healthcare services, underuse, and then misuse in terms of the wrong service or wrong time, wrong provider, et cetera. And our approach to estimating cost impacts includes, but it's certainly not limited to, the programmatic costs. The local models, are we really perhaps in some ways finding how to use or maximize existing resources rather than creating new ones? And that often brings us to the point of redirecting existing services so that they are maximized in terms of their utilization and their impact. And then again, of course, what's the time frame that we're looking at? Even in the last 20 years, I think we've moved to time frames that, whether it's prevention or health promotion activities that may have been 10, 20 years to much shorter time frames, the more we can better understand the impacts that the cofactors, the working over the last 2 decades. We are fortunate here in Durham County, our home county, to have engaged leadership in all levels of health and human services, and that has certainly provided an excellent platform to be able to think creatively and move creatively in terms of designing new services and redirecting existing services. We have an amazing environment here, being, for the most part, the single provider in our community. It's Duke and it's Lincoln, and when you put that data together, you really see a pretty good picture of about 95% of our community. I know that's a very unique situation when you look at other parts of our state or our country, and certainly our deep knowledge of local conditions and how that impacts our ability to help to change policy. Ultimately, though, and I'm going to finish with this and ask Mina to join me here to go in a little bit more detail around our research and some example programs, and then we'll follow Mina with yet a little more deeper dive. What it really has amounted to, what our 2 decades of work has amounted to, is understanding that the key component of the interventions, no matter what we do, and the key component to sustaining them, has always been to ask, investigate, collaborate, implement, and evaluate at the intersection of health, equity, and place. You always have to have those 3 pieces at the forefront of every action you take as we go through in terms of being able to sustain programs that improve the health of communities, improve the health of populations. It has to take into account the context and constructs of people's lives. And so far, we haven't seen any way we're really getting around that. And it has indeed, I think, been what we've distilled down to the basis for the success of the programs that we've been able to keep moving and seeing some pretty incredible outcomes in terms of improving the communities and populations that we work with. Mina?
So can folks hear me, or do I need the other mic? Okay, thanks. Really great to see all of you here today, especially some familiar faces. I'm just going to give some examples from my work of some of the research and evaluation that goes on in the division. And as I was thinking about this, it got me thinking about what's the glue of my work. And I would say the common elements are that I tend to focus on solutions. So I'm not an epidemiologist. I'm not looking at the etiology of the health problems and health disparities that we're interested in, but I'm doing essentially intervention research and evaluation on potential ways of addressing those problems. Looking at under-resourced populations tend to be low income, but may also have other barriers to access to care, for example, age. It's effectiveness research, really looking at how interventions work in a real-world context. So if things have, generally looking at things that have shown some efficacy in other kinds of research and seeing how we can apply them in what we're doing. Although you'll see that's not 100% true. I think one of the things that characterizes my work is that I want to get inside the black box. So not just interested in, what the outcomes of something are, but why. What worked well, what didn't work. And I tend to try to use the tool that matches the task. Obviously, I depend on the kindness of strangers because I don't, have a full command over all these tools. I'm going to talk later about a project that Doc Mulbauer was our statistician on. It's great to see him here. But we tend to use mixed methods, which really makes sense if you think about looking at outcomes as well as process that leads you to those outcomes. And I guess one of the things that I find is that often, especially with learners, they want a hypothesis and they want to do inferential work and they want to do causal work. But sometimes for our purposes, which is really in part just to support the kinds of programs that Michelle is talking about, descriptive research can be extremely valuable. All of the work that I do is stakeholder engaged. We need stakeholders to help us define the questions that need answering and for the kind of work that we do. I'm not saying this is true across the board. And to help us determine how best to get the research done in that real world context, to interpret our results, and then ultimately to promote the use of what was learned. That said, there is diversity in the kind of work that I do, and I've put it for some simplicity's sake on your classic 2x2 matrix here. So one continuum here is the extent to which it's research versus evaluation and planning. And I'm using the traditional definitions here that research is for the purpose of creating generalizable knowledge, whereas evaluation or planning is for the purpose of informing decision-making around a specific program. That said, I think there is a lot of gray in there, and I'm going to talk about that as well. And the other axis here is the extent to which we're looking at clinical solutions to health issues versus community solutions. We have recently, in the last few years, added on another piece, which is that we evaluate our own work. And so that's sort of off the matrix here, but I wanted to mention something that we were excited about was we do a partner survey with both our internal Duke partners and our external partners every couple of years to see whether how they feel about the collaboration that we do with them. And that was recently featured as a best practice in a publication of the American Hospital Association with a variety of partners. So just to show you a few things where they fit on this matrix, and this is, I've been here for 14 years, so these are just samples of what we've been doing. But so one example I'm going to talk about is evaluation of our own internal clinical programs. In4Kids was a study that we did funded by the Health and Wellness Trust Fund to look at the feasibility and effectiveness of integrating registered dietitians into primary care clinics to work with overweight kids. So it's more on that research spectrum, but still very clinical. African American Health Improvement Partnership is the project I worked on with DOC. It was an NIH-funded community-based participatory research project led by Sherman James. So very much on the research side, but now we were looking at community-based approaches to improving diabetes management. Healthy Places North Carolina that Emily mentioned before is an evaluation of the KP Reynolds Charitable Trust's Healthy Places initiative, which is very much a community-based approach to health improvement. And then Tenancy Support Services study funded by the Robert Wood Johnson Foundation, which is research to assess how best to provide tenancy support services to homeless and institutionalized people to help them with transition to community-based housing and maintaining that housing, which is a known determinant of health. It's largely being done to support policymaking in the state of North Carolina, but also I think is more generalizable in nature than some of the other stuff over here, so I've stuck it in the middle. So I'm just I have a bunch of slides and I've asked Anh to give me the high sign when I only have 5 minutes left, so I'll kind of see what I can get through here, but just to give you some examples. So some of the main questions that we ask when we evaluate our division clinical programs, we have to ask about patient satisfaction. That's required for all Duke clinical programs. I apologize for my phone. Are we meeting needs? Are we meeting real needs in the community that, after all, is, as Michelle discussed, the justification for what we do? What do our clinical outcomes look like, and what's the benefit to the health system, which is, after all, where we live, and has an investment in some of our programs. So I'm just got a few examples here to show you. So one of the things that we found right away when we started looking at our elementary school clinics is that compared to the high school clinic that we had, they had lower utilization rates, they had lower acuity of the visits. Honestly, and when I say lower acuity, like a lot of the visits were things like, I need a Band-Aid, I had an accident, and the kids who were in those clinics were more likely to be being taken to a clinic outside of school than the high school kids. So whereas in the high school, it seemed like there was a big need for the acute services, the sexual health services, the mental health services that were being provided. In the elementary school clinics, it seemed like the need level for the acute services at least was less. Actually, a lot of need for mental health services, and ended up getting a grant to help meet some of that need. But it certainly kind of brought into question, is this model really meeting an important community need? And so now, years later, those clinics have really transformed their model. And now what they do is to actually focus on preventive services that kids were not getting outside the clinic. So moved away from the acute model. So I think it's a nice example of how we truly try to look at what we're doing and ask the question with our data of whether it's fulfilling our goals, and then respond to that. Just for Us is a program that Michelle mentioned. This is an example where we looked at clinical outcomes, essentially saw some nice, strong data about improvement in hypertension control in that population. That was 85% of the people had hypertension. One of the things that we were excited about was knowing that there is a lot of disparity in terms of who benefits from health improvement interventions, that in fact in our population the improvement was greater for African Americans in the population as opposed to less. So that was nice. Here's an example of another way that we looked at the question of were we meeting community needs, and what was the impact for the health system. So this is Lyon Park, which is one of our neighborhood clinics. And the thing that I kind of like about this is that we did this in a very simple way. We started out thinking about all these really complicated stuff we could do. Of course, we didn't have all this lovely access to the EMR at the time. So to actually go into people's records would have been an enormous investment. But these clinics are actually pretty low cost. And so the level of evidence that we needed in terms of sharing with the health system about the impact that we were having was I think is commensurate to the cost. And so all we did was essentially ask people when they came in, if this clinic wasn't here today, what would you have done? And so what you see is that there are a lot of people talking about that they would have either delayed getting care for this need, gone to the community health center, which was incredibly populated at that time in terms of huge patient waits, or gone to the hospital emergency room, which is obviously the one that the health system is going to care about the most. And that was about a third of folks. And we split it up in terms of drop-in patients versus scheduled for our own planning purposes. In other words, was there a difference in which need was being met? So you can see here, for example, that having drop-in option really helps with the ED diversion. This is just another way of looking at this, where we looked at all the combinations of those different options. And you can see here, 29% of people, the only other option that they would have considered was going to the hospital emergency room. And one of the interesting things, she just gave me the high sign. just give you a couple more examples. This is the In for Kids study, and what we were looking at was change in BMI for kids in the clinics where we had integrated the registered dietitians versus historical comparison group in those same clinics. No difference, right? But here's a nice example of looking inside the black box. And the thing that I would refer you to here is we looked at the percent of the eligible patients at each clinic, in other words, the kids who had high BMI and needed these services, who were actually referred by the doctor to the free registered dietitian at their clinic. It's 19%. So not a big surprise that we didn't see any difference in the outcome for the intervention and the historical comparison group. That then got us to the question, why aren't the referrals being made? AHIP, this is just an example, I mean, kind of going beyond the outcome data to look at the question of, were we meeting the needs of a needier population, essentially, than are making it into the Duke Health System? I think that in the interest of time, the interesting thing that I would look at here is that even though we were getting people with higher baseline HbA1c into the study than we found in the health system, we had an issue with disparity in completion rates amongst our folks. So the people who tended to actually complete our 6 months of intervention were older, higher income, and had lower hemoglobin A1c to start with. So an issue that we were concerned about. I did a talk recently for the Center for Community Population Health Improvement on the Healthy Places evaluation, so I'm not going to go into this, but I think this is an interesting example where even though this is evaluation, there are really some generalizable lessons here, and we have a recent publication in AJPH about that. I'm just going to end by talking about, oh dear, sorry, somehow the font size got changed and messed my thing up. This is our Robert Wood Johnson funded project that we're just beginning, looking at how do you provide effective tenancy support services. So we already know this. There's already plenty of research showing that tenancy support increases housing stability, and there's tons of research showing that housing is associated with health. And then some tenancy support actually directly affects health through getting people linked to access to care and so forth. The question we're asking is this one: how do you provide effective tenancy support? So what does that even mean? What are the key outcomes? What are the practices of effective provider agencies? What's in the regulatory context that supports effective TSS, as well as the market context and so forth. So this is essentially a case study project. We're looking at the example of Louisiana, which has quite a long history of funding this through Medicaid as well as other sources, and is reasonably similar to North Carolina in the structure of its Medicaid. And then we're looking at very successful agencies in North Carolina as well as Louisiana to sort of learn from their practices. And the data sources for that are a combination of reports, archival materials, administrative and encounter data, and then the most important piece really is key participant interviews and focus groups. I'll turn it over to
Good afternoon, everyone. Thanks again for having us here today. So as Michelle mentioned earlier, I'm going to take a little bit of a deeper dive into one particular research program that we somewhat longitudinal, so to speak, for about 6 years. I'll tell you a bit about it and give you, and this is more sort of the full-blown community-engaged research or community-based participatory research model that we tend to sometimes use as a model in our research within the division. And the name of the program is it's ALMA, which stands for Amigas Latinas Motivando el Alma. For those of you familiar with Spanish, Alma is translated to soul, Latina Friends Motivating the Soul. And as the title indicates, it was a community engaged research initiative. We worked with Latinas in the local community to improve and address mental health outcomes. And it really is this journey from intervention to photo voice to Facebook, and I think this all makes sense a little bit more once I dive a bit deeper into it. So I'm not going to go over again what Mina and Michelle have covered fairly nicely already, is that our initiative started with UNC. It was a health disparities consortium, a group of health disparities researchers getting together between Duke and UNC, and we were fortunate enough to be funded by GlaxoSmithKline Foundation with a health disparities grant, and we had this nice privilege of not being tethered to a particular population, nor even health condition, nor what type of research or service we wanted to provide, but it really was this organic opportunity to unfold through stakeholder engagement. And we very much focused on the principles of collaboration, which Michelle and Mina have covered already. So a little bit of background, it was a 6-year collaboration, more or less. We started out with an initial 3-year grant. For our first phase, we had some no-cost extension time, and then we applied again and were given another 2-year grant to do a qualitative component of the research. And so first we did, we got together, we said, okay, who are our community partners? Who have we worked with already? What type of populations are we interested in? But ultimately, we needed to go out to the community and talk to the members and leaders to see what was important for them to address. And not surprisingly, even though we as researchers obviously have our own preconceived ideas based on literature, epi data, what have you, but they surprised us. And for full disclosure, I did not join this initiative until I think about midway through the program, joined as a co-investigator and evaluator, and Michelle can give more details later if you have any questions. She was there from the ground up. And so what I've been told, it's been shared with me, is when we started asking questions in the community, is there need? What's culturally appropriate, acceptable? Who's being served? Who needs what? And we were taking a look, having conversations with those who were involved with providing services in the Latino community, which at that time was really burgeoning and growing. They really surprised us. What ended up coming up was not about physical, acute or chronic physical health needs or concerns. It was about mental health. They said, this stress is killing us. I mean, our day-to-day, what we're going through, it's affecting our families, personal lives, professional lives. It really is cascading into so many different areas of coping with the day-to-day stress, especially as individuals coming from immigrant communities. And if you're going to help us, this is what we'd love for you to focus on. So that's exactly what we did. We recalibrated. Our team was not expecting to dive into mental health or that arena. Truth be told, not even everyone had expertise in that area at that time, so that's when we relied on our community engaged partners and leaders, and then we went from there. And that this image on the side, what it represents to us and to them at that time, they said it's like a pressure cooker, and this is what happens in the effects of unmanaged stress, and that's what they were feeling. And so with input from our community and academic advisory committee, we responded over a period of time, of course, with really intense engagement, developed a culturally tailored curriculum, which we titled ALMA, to address some of the mental health outcomes and sort of preclinical depressive states that individuals found themselves in, and hoping to address it at the individual and interpersonal level. And then this was based on a model of training with promotoras, which some of you may be familiar with as lay health advisors. And we hope that they would be the venue, the conduit, to then pass it along to other individuals within their social networks, who we call compañeras. So why Latinos? And as I alluded to earlier, at the time, it continues to be such a fast-growing population in North Carolina, with great increases starting in 2000. And at that time, actually, Durham County was the fastest-growing Latino population in the country. So the services that they needed, the things that needed to be addressed, both physical and social services, really the county was not able to keep up with. And it was really a moving target for this community. They didn't really make it into many mainstream services that were being provided and programs. So it was a challenge initially, you know, to figure out what's right for the community, what's reasonable and what's feasible. And, you know, as Michelle and Min have mentioned, the community largely uninsured, low income, very resource deprived. And then in terms of, you know, why mental health? As I said earlier, you know, the stressful experiences that Latinos and immigrant communities face before, during, or after their journey to North Carolina puts them at increased risk for various mental health conditions. So then now why Latinas? Because I mentioned that we worked with Latinas. And why promotoras? Well, in Latinas, the women in the community are at heightened risk, like their male counterparts, certainly due to issues of stigma, limited access to mental health resources, oftentimes, sometimes we're in situations of domestic violence, various gender role expectations, and all these things bundled together really made it challenging for them. And they, not uncommon to other households, were really spearheading many different household management issues, caring for the children, trying to help the family move and assimilate along into society. So they were really at a very high stress, angst level, coming into the program or when we approached them. And they're less likely to access, when you look at the data, mental health services, and also they seek mental health services much less than their US-born female counterparts, and receive them less as well. And in terms of promotoras, or lay health advisors, for those of you who may reside in this area, they're natural helpers already. They can be a great strength in the community, so why not leverage that? And research has validated a lot of peer evaluation, education via lay health advisors or promotoras. We wanted to see if peer education could be a successful technique to provide information and facilitate behavior change, and potentially, again, the key word is sustainability. Can this continue on after this intervention or program is over? Oops, a little jiggling of the formatting. I apologize. So in terms of our stakeholder engagement, I mentioned earlier, we had a very large community advisory community and academic advisory committee. Initially, it was about 24 individuals who sat around the table. About half were from an academic research background, and the other half were a variety of different community stakeholders and leaders. Initially, we had them meet separately, or we met with them separately, but over time it evolved to, we said, why not everybody at the same table? There's a lot of synergy that can happen, and indeed it did. This committee was pivotal in helping us move along and develop our different phases of the curriculum, the intervention, guiding us in terms of ideas for implementation and evaluation. And as a large committee, it met about twice a year, but then individuals broke up in smaller work groups all throughout, especially during the development phase, to move along the activities. And you can see a list of different contributions that committee members provided to us. They really rolled up their sleeves and dived into it. Everyone was really passionate about it. This was not a passive, we'll just meet together, give you some ideas and go away. It was from recruitment to, we'll share space with you. This is how, some co-facilitated training sessions, depending on their area of expertise. They were very much invested in the project and in ALMA. So in terms of phase one, the specific aims is, once we had the curriculum, we wanted to test the feasibility. What's the feasibility of recruiting and training promotoras on stress and coping skills, and then transferring that to peer dissemination within the compañeras, other members of their social network, to improve their stress reduction coping strategies. In terms of the impact of the promotora training, as you can see on the slide, we wanted to see if we can move the needle on, knowledge, attitudes, and some behaviors, knowledge of mental health resources, where they're understanding how they can communicate with their health providers about mental health issues, or, the stigma that goes along with mental health. Does that subside a bit after they know more about the constructs and concepts of mental health? And ultimately, is there any improvement at all in terms of preclinical depressive symptoms, anxiety, coping skills, are their social networks stronger? And we measured this not only with the compañeras, the individuals to whom our promotores outreach, but we were very curious about the messengers themselves. Did the training have an impact on them? Did they change at all? And so for those of you who are involved in lay health advisor interventions, sometimes that is not evaluated or evaluated well. You usually focus on the second tier, the ripple effect, but not much is understood about those who are sort of training the trainer and moving along. And with this population, because we felt like they too were struggling with these issues, which is why they wanted to be involved, we wanted to capture that and see where the needle can move on that. So in terms of the pilot intervention, we aim to train about 45 local community promotoras across 3 counties, Durham, Wake, and Chatham. And the curriculum, the training sessions were 6 to 10, and I'll explain that a little bit. Initially started out as 10 sessions that the training curriculum was involved. 10 weeks, 10 sessions, about 2 to 3 hours each session. And each wave would train about a dozen or so Latinas, the promotoras. They were recruited through a variety of locations and sources, skill building on a lot of coping strategies, and we included in the curriculum relevant topics that they had shared with us that really impacted their stress level or lack thereof. And different tangible items, we used different levels of education, kinesthetic, is it visual, written, there was theater performance, lots of different things to kind of draw them out and get them engaged with one another and the facilitators. And then after they were done, then we asked them to reach out to at least 1 or 2 of their Latina social network members, the compañeras, and for them to pass along the self-help strategies and the knowledge that they had learned within the training. And this is just a snapshot, I won't go over it, but sometimes people are curious about some of the topics and so forth. Initially, it did start as 10 sessions. Later on, this is a process. Eval is important to us. So once we went through the first round, due to logistics and other issues, it became more feasible and advantageous for us to condense it down to 6 for the next 2 waves of training. We kept many of the same topics. We just somewhat collapsed it a bit and lengthened the sessions out, but it was easier for them to show up for 6 times versus 10, but those are some of the main curriculum topics. And here's some images of the different activities and the women who are involved in the promotora training. The very last session of the curriculum involved a graduation and celebration of the women completing the training, and they were able to invite their family members, and it was a very celebratory time for them. So pre-post eval, these are some of the various metrics that we are interested in terms of behavioral health outcomes, and some of the things I mentioned to you already. And then what did we find? So in terms of our pilot findings, some of the key findings, and all of these findings were statistically significant. 1, there was an improved understanding of symptoms and reasons for depression. There was also increased awareness of the mental health resources that were around. There were reduced levels of perceived and acculturated stress, and we used, to the extent possible, validated scales that had been translated to Spanish and tested before. And also decreased symptoms of depression and anxiety. And although certainly a small number of individuals, a small period of time, what was starkly stood out to us was the level of decrease of their reported preclinical depressive symptoms. In both groups, it went down 40 to 50%, and we were quite surprised. A good number of them coming in at baseline would be categorized sort of the preclinical depression level. So that was really stood out to us. And also there was an expansion. They report an expansion of their social support system. So just some numbers for you. A lot of what I've shared with you is available for further elaboration in some of the publications we have. The promotora results, first we looked at, and again, what I've shared with you already, these are just some of the movement in terms of seeing it visually. And then the compañera results were similar as well and also statistically significant. I've gone over some of the key points. So then we moved on to phase 2. And so what we're interested in phase 2 is, okay, so now this is just sort of a one group, pre-post, eval. Let's see if we can pilot test this intervention having a comparison group involved as well. So we reach out to our partners in Wake County, which is also a Latino service providing community, and they had lay health advisor programs that were ongoing on different topics, so they agreed to have one of their lay health advisor groups serve as our comparison group. The data's in, we're still sort of sorting through the various nuances of it. It's a very small number, but for now, things seem to be moving the direction which makes it's encouraging that that the change that we saw in the new intervention group was more pronounced than that in the comparison group, but we're still exploring. The initiative I want to dive into a bit with you is Photo Voice, and I don't know how many of you are familiar with it or have ever heard of it. It is a qualitative participatory research data gathering method which is used to reflect on community strengths and concerns. And so we involved a group of promotoras in Chatham and Durham County to be involved in this qualitative research component of ALMA. And from there, they were asked to focus on mental health concerns and some of the root causes and what they felt was going on in their community in terms of they felt like could be helpful for intervention development, but doing it through the lens of photography. So, there might be a topic, and the promotoras would go out and capture images that they felt address the topic, and we would go back, and there's this intense methodology that you go through and you discuss and you come up with themes together and kind of consolidate. So those of you involved in qualitative research might be familiar with it. So once that happened, and quite a few themes came up, across the counties. And what we did was we condensed down to about 7 themes. And I'm going to share with you just 2 of them that came up. And again, things that we didn't necessarily know or think were on their minds, but it was. And so one of the themes that kept on coming up was about, it was summarized as regulation and inspection of housing complexes. So the individual who took this picture shared this quote with us. "It's really sad to see how people, because of their lack of knowledge about their rights, continue to live like this. This is also part of the minimal conditions that we have a right to." And this is translated from Spanish. So we can address this perhaps through the supervision of apartment complexes and the education of our people. Another theme that came up that they said contributed to their great angst, stress in the day-to-day, was what was summarized as racism and discrimination against Latinos. And the quote that goes with that is as follows: "Although sometimes one might say that you can go to the police and tell them if something's happening to you, if there's a problem, but unfortunately there are times when it ends up being counterproductive. You go and instead of them helping you, they end up harming you. The police have focused more on whether you're legal in this country than on the situation that you're going through or what's happening to you." So what culminated with all these photos and all this data, and is usually standard in Photo Voice, is community forums are held. And it culminated for this program, community forums that took place in Durham and in Chatham counties, and it had from 35 to 70 people attendance at each of the forums. They were planned and run almost exclusively by the promotora, setting the agenda, organizing, facilitating, leading the sessions, talking to those who attended and sharing with them what came out of Photo Voice. And the guests included individuals like you and I, people, researchers, academic institutions, religious leaders, community leaders, even local government officials, just a variety of individuals who might have an impact in some way or might have some feedback on what is shared. And it was really an opportunity for the promotors to share their concerns and to brainstorm with the audience, what might be done to address some of the issues they brought up. So what did they bring up? They brought up, like I said, there was about 8 themes in general that were shared, and then some of the action steps that came out of these forums, which had really terrific, rich discussion. Individuals who were obviously already invested in these topics who came. And to share with you, I won't go over all of them, but for example, ideas came up such as, can we unite churches and provide dismantling racism workshops? Could we perhaps adapt and design an ALMA program for men? People wanted to figure out ways to learn more about immigration and laws protecting Latinos and how to do that for community members and others around them who supported them. And finding ways to educate others on housing regulations. And there was a theme that had to do with youth, and which is why it says finding scholarships and other educational resources for Latino youth. So we had two formal phases of ALMA, but this idea of sustainability that Mina and Michelle have mentioned, this is sometimes what happens when you've gone along this way with stakeholder engagement, you've empowered individuals, you've really given them a lease and a lens to look in a different way and see their impact. Then what we had next was we call the informal ALMA Phase 3. And to share a little bit with you, there was a creation of what is called ALMA Coffee. And so what happened was a group of the Photo Voice promotoras, after Photo Voice was over, after the formal ALMA program was over, they said, you know what? Why don't we continue meeting over coffee? We've done all this community engagement, community building. I mean, we know so much more. We can do so much more. Then why stop here? And so from there, they continued to start meeting, talking about future plans, what they might be able to do as advocates for their community, and organize their communities around topics that were important to them in the forums. And they called it ALMA Coffee, a Latina support network, and they had plans for future actions regarding community concerns. And then it went on to a Facebook page, and at a certain point, I believe they hosted a community forum on Facebook, and close to 50 individuals attended and were active on that particular Facebook community forum. And then through their request, the ALMA team linked to them to an initiative called Linking Immigrants to New Communities, to the promoters in their church community to receive some additional education about legal rights and how immigrants can more effectively be incorporated into their communities. And here's a list for you. I won't go over it, but ALMA Coffee has continued to be very busy and very active. They've engaged both with Duke and UNC, have really helped out on different research initiatives, but also continue to be involved in the academic arena as well as being involved in their own communities and are in the creation process of their own 501c organization. And to show that, there's co-ownership of products and things that come out of this. So true to our community engaged research paradigm and model, our promotoras and participants have been involved with us in co-presenting in both oral and poster presentations, both locally and nationally, sometimes nationally through the technology of Skype and some simultaneous interpretation technology. They've been able to co-present with us, and we're really excited that this past year a few of our promotoras also were able to co-author a publication with us that was accepted regarding the process and outcomes of ALMA Photo Voice. So dissemination and next steps. So once we started publishing on ALMA, what started happening was we started to get quite a few inquiries around the country about the curriculum, which I showed with you earlier. There seems to be, for many different sectors in the U.S. that work with Latino communities and other communities, they were interested about the content and the delivery and wanted to see if it might be something that's applicable for them. Interestingly, it has been piloted and replicated in various modified forms, both here to our knowledge when folks inform us, both in the US and in Mexico as well. And just a few months ago, at the beginning of the year in January, we submitted with some colleagues at the University of Washington and other locations an R01 application to continue and expand ALMA and test its efficacy. And so to be continued. Thank you.
So right at 1 o'clock, if you guys are willing to stay a couple minutes and maybe take a question or two, and then if there are additional questions, maybe the audience members can follow up with you individually after the session. Questions?
I'll venture one. How do you partner with, or who do you partner with on the cost effectiveness analysis? That's always such a challenge in research work.
It is. We have been fortunate to partner with our own health system in terms of the clinical services and some of the pieces I did not share in terms of what we look at through our performance services and our finance folks. They will work with us in setting up ways, a number of different ways in which we look at the financial impact and or the averted financial impact, although that argument in itself often meets with some tension in terms of trying to prove averted costs, but that has been our main partner in setting up a lot of the financial models.
Thank you.
It's a great question. I just want to put a plug for Don Taylor at the Sanford School. He's at least proposing to, I don't know if he's done it yet, but some work around really doing community engagement to figure out what the important components of cost effectiveness should be, specifically around palliative care. And
Maybe one quick question. So, actually, maybe not that quick, but as you all know, there's a lot of interest in patient engagement and research, and that's really exploded over the past couple of years. And it strikes me that this is something that you have all been doing successfully for decades, and maybe just using different semantics to describe the same thing. But it also seems that there's so much expertise in your division and more broadly the community stakeholders that you work with on best practices for navigating that process, which can be difficult, and also how to make those initial connections. And I'm wondering if there are, besides just a brief 1-hour talk, opportunities for Duke investigators to learn from you all about what works well, what may not work so well, how you make connections in a community that may not already be part of your the populations that you study. Have you collaborated with folks on just the planning for how to do that work sort of before any of the actual research starts, and how can investigators from DCRI leverage some of your expertise? Do you guys want to go?
Sure. So yes, we have provided that kind of input to investigators, and the extent of the input has ranged from just a conversation to actually collaborating on the project. So you mentioned, for example, that I'm an investigator with Deb Tucci on a project that they're doing, which is specifically around engaging primary care clinics for hearing screening for the elderly. So the extent of the collaboration actually ended up being something where I'm an investigator on the funded project. So.
And while we're helping to develop, obviously, the Center for Community and Population Health Improvement, we've all three of us have been involved with the CTSAs since their inception of the first one in 2006. As Mina pointed out before we actually started the talk, we tend to stay a little bit under the radar, but we're always happy to help. And whether or not it's even just in a sort of a consultation or just talking with folks, and not necessarily being a part of then their ongoing research endeavor or their submission, but just as a resource, having sort of been around for so long. So.
I hope you don't get flooded with emails, but if it happens, it's because your talk was great. So, thank you.
Thank you.
Thanks.